you for joining us today. We'll be starting in just a moment. We want to give people a couple more minutes to join. Hang in there. We'll be back in just a moment. Thank you. Good afternoon, everyone. My name is Lisa Yurts. I'm Physical Therapist and Regional Director at Spear Physical and Occupational Therapy. I'd like to welcome back those of you who have attended one of our other webinars, as well as welcome those of you who are joining us for the first time. This is our second pelvic health webinar, and we're excited to be back with all of you today. We really appreciate you taking time out of your day to learn with us. For those of you who don't know us and who we are, we're Spear, a private outpatient practice that has been around for over 20 years with currently 20 locations all over the New York City area. We have successfully continued to offer in-clinic care, as well as launch Spear Live for those who are looking to stay in and receive care using our telehealth platform from the comfort of your own home. In our clinics, we are strategically going above and beyond the CDC guidelines to ensure the safety and well-being of everyone. You can find more detailed information on those safety measures by visiting our website at spearcenter.com. We're here for you in whichever way makes you feel most comfortable. So if you're looking for individualized care, either in clinic or through telehealth, please reach out to us at your convenience and we'll get you set up for an appointment right away. Since hosting our first pelvic health webinar about a month ago, we received a lot of positive feedback from all of you and great follow-up questions from the community. We're here with you today, backed by popular demand, to do a recap of the important points that we covered last time, present some new information on similar topics, and spend a bit more time answering questions from all of you. We're excited to be able to offer more advice and education on this topic. As part of our session today, we're going to be talking through and demonstrating some self-massage techniques, and we welcome you to follow along and practice with us as you feel comfortable. Please note, though, that if you experience any pain while performing any of these, definitely stop and reach out to us directly so that we can support you. So we created today's talk specifically for you, and we're coming to you live from our own home. We don't anticipate any technical issues today, but please be patient with us should any arise as we navigate through the technology. So as I mentioned, throughout the webinar, we want to hear from you. If you have any questions at all, please feel free to let us know your thoughts in the Q&A feature at the bottom of your screen. To find this, you want to hover your mouse at the bottom of the screen, and you're going to see a Q&A option pop up. That's where we ask that you put in your questions, and we'll do our best to address them as best we can throughout the webinar and during the Q&A session at the end. For those of you who are watching through YouTube Live, we're also monitoring comment section there, so please feel free to type questions as they come up. So let's talk more about our goals for the day and what we'll be covering. Similarly to last time, we're going to review the basic anatomy and function of the pelvic floor. We're going to review some of the do's and don'ts for healthy bathroom habits, bust some common myths and answer frequently asked questions. We're also going to demonstrate those self-care techniques for you to do at home and those self-massages. And then lastly, we're going to leave a little bit of extra time to answer questions that you all have. Okay, before we get started, I'd like to introduce you to our team of panelists. We're all returning from the last time, so let me welcome everybody back onto the screen. Hey guys, thank you for joining. Okay, so we have Devon Dinegar, who's a pelvic health therapist and from our Brooklyn Heights location. Hey Devon.
Hi.
Next, we have Jessie Weinberg, who is our pelvic health program director, as well as a pelvic health physical therapist from our Broad Street location in the financial district.
Hi, everyone.
Jessie. And then lastly, we have Nicole Sirach, who is a clinical director and physical therapist at our Brooklyn Heights office. And she's going to be the one helping us answer some of the questions in the Q&A today as well.
Hi there.
Okay, so what's up, guys? All right, so Devon, Nicole, and I are going to say goodbye for now. Jessie, we're going to let you take it away with some anatomy information.
Wonderful. Before we get to the anatomy, we're actually going to start the webinar off with a poll. So give us 1 second for us to pull that up. Our poll question is, did you attend part 1 of our pelvic floor webinar? We just want to see who's a returning guest and who is coming to us new. So take a second, answer that. All right, so we have about 30% of you guys as returning guests, and then we have 69% who are new. So wonderful. Thank you everyone for who has come back. Thank you for coming for round 2. And for those of you who are new, welcome. We're excited to have you here. We are going to review some of the anatomy, some of the pelvic floor muscles. We're going to review some of the healthy bathroom habits before answering new questions. So for those of you who joined us before, stay tuned. We are going to answer some new information, but for those new people, we do want to kind of give some background to help us understand the answers to the questions. So first, we're going to go over our anatomy. So you guys can see the musculature here up on the screen. So the pelvic floor muscles are the muscles that surround the pelvis, and they have 4 major functions. We have bowel function, bladder, sexual function, as well as support for the pelvic organs that sit inside. The muscles are oriented in 3 layers. You can see here on the upper left side of your screen, we have the superficial layer. And this layer here is in charge of our sexual function as well as closing the vaginal opening. And then we have our layer 2, which is on the upper right side of the model here. And these muscles are kind of in charge of our sphincters and our bladder. And then we have our deep layer, our layer 3, which is the lower part of the pelvis. And this is in charge of our support. So not only do we have female pelvic floor anatomy, but also if we go to the next slide here, you'll see the male pelvic floor anatomy. And as you guys can see, this anatomy isn't much different from the female anatomy. So at the top here, we have the triangle at the top, which includes those superficial muscles, very similar to female anatomy. This is in charge of our bladder function as well as sexual function. And then that deeper layer below is in charge of support. So we have our anatomy there, both female and male. So now we're going to bring Devon on the screen to talk about the 2 main categories of dysfunction.
Hi guys, thank you Jessie for that anatomy review. So I just want to talk today about the 2 classifications of the pelvic floor muscles, those being hypertonic and hypotonic. Hypertonic means that your muscles have more tone and are overactive, contracting too much and or too frequently. Hypotonic, on the other hand, means that your muscles have less tone and are underactive. So let's talk about how these 2 muscle classifications might present. So muscles that are hypertonic may cause tightness, pain, tenderness, bladder and bowel dysfunction. Stress has been shown to directly affect pelvic floor hypertonicity, although unfortunately, sometimes the cause is unknown and we don't know why, but something that we can fix. So you're in the right spot. Muscles that are hypotonic have less tone and are often underperforming and weak, which most commonly leads to urinary and bowel incontinence. However, hypotonic muscles can sometimes be painful and tender, and we most commonly see that in women after having a baby. So that's our 2 classifications of muscles. We want to now review some healthy bathroom habits. So those of you who joined us for our last webinar, you can feel free to answer these questions before I do. So we'll start with bladder norms. So you should be urinating every 3 to 4 hours with moderate to strong urge, with your stream lasting greater than 8 seconds. You should not be going to the bathroom just in case, because going to the bathroom just in case is going to reduce your bladder's tolerance to fill. So for example, if you go to the bathroom just before a meeting or just when you're leaving the house or when you're walking past the bathroom just in case, you are reducing your bladder's capacity to fill. And we don't want that. We want your bladder to work as effectively and optimally as possible. Once you reduce your capacity to fill by going just in case, you're going to send a signal to your brain that's going to give your brain a false sense of urgency. And you have kind of over time trained your bladder to think that it's fuller sooner. But there are definitely ways that we can retrain your bladder to make you realize that your bladder is probably just playing tricks on you. So for tips on how to reduce just in case urination and bladder retraining techniques, please watch part 1 of our pelvic floor webinar that's up on our YouTube channel. But let's talk about waking up in the middle of the night to urinate. So if you're older than 65 years old, it's normal to wake up 0 to 1 times per night because you have to go to the bathroom. If you're younger than 65, you should not be waking up in the middle of the night. If you're pregnant, waking up in the middle of the night is common, but it should not linger into postpartum. So another thing we want to talk about is do not hover when you're urinating. Be sure to sit and allow your pelvic floor muscles to completely relax. That's very important just for proper posture or having a urination. When you are going to the bathroom to have a bowel movement, your stool should be soft and sausage-like. Frequency for this varies greatly. It ranges from about 3 times a day to once every 3 days. Not everyone has that perfect once a day bowel movement. We want to make sure that you're not pushing or straining or hovering, as we talked about with bladder habits. And we want you to develop a morning bowel routine. So don't spend more than 10 minutes in the bathroom. That's another important factor. For an in-depth review of proper bathroom habits, please watch part 1 of our pelvic floor webinar series on our YouTube channel, as I mentioned. So let's pull Jessie back in so we can begin to answer your commonly asked questions and open the floor up for a live Q&A. All right, so hi, Jessie.
Hi, nice to be back.
All right, it feels good. So let's start with the bladder question. So Jessie, I gave birth 10 years ago and I'm noticing I still leak when I sneeze and when I work out. Is this normal at this point after 10 years? Is there anything I can do to stop leaking?
Yes, good question, Devon. We did actually answer a very similar question in part 1 of our webinar, but we got a lot of questions about this, so I do feel that it's important to review this. So what you're experiencing, or the person asking this question is experiencing, is called stress urinary incontinence. This means when the muscles are under physical stress, like sneezing, coughing, laughing, jumping, you have some leakage of urine. So this is common after pregnancy and childbirth. However, this is not normal. Okay, we should not be experiencing this forever after giving birth. The most direct exercise you can perform to help strengthen your pelvic floor is called a Kegel. Kegels are a pelvic floor muscle exercise in which you draw your pelvic floor muscles up and in and hold. My favorite visual cue, which I mentioned last time, is to draw up and in like you're picking up a blueberry. But you can also picture, drawing up a cloth handkerchief or an elevator rising, whatever cue works for you is totally fine. So you should work on holding this contraction for, longer holds, as well as quickly contracting and relaxing your pelvic floor. It's also important that if you're experiencing these symptoms, especially when working out, to strengthen the muscles surrounding the pelvis. So this includes the glutes as well as the core. If you're still confused about how to do a Kegel, or if you have pain with Kegels, it may be best to have some guidance and supervision with a PT.
Great, thank you, Jessie.
Yeah, so we're gonna move on to our next question, and this one has to do with bowel function. The question is, I often feel a bulge or difficulty evacuating my stool, and I use my hand or finger inside my vagina to help release the bowel movement. What is this?
Yeah, so Jessie, the technique that you're referring to is called splinting, and it's typically used when the rectum is not in the most optimal position. So it's either secondary to aging that occurs, or if you have a pelvic organ prolapse. Because of the rectum's position, it requires pressure to adjust the orientation of the rectum to improve evacuation of stool. Another method, if you are not using your finger or you're uncomfortable with using your finger, but know you might need that, you can use a pessary. A pessary is an insert that's placed vaginally and can be fitted by a urogynecologist to better align your unique pelvic floor orientation of your organs and allow for easier evacuation. If you're not sure you're the right candidate for a pessary, you can always ask your pelvic floor therapist or your gynecologist, who can hopefully lead you in the right direction for a urogynecologist.
Yeah, I think that's a great point, Devon. You know, there are some over-the-counter pessaries, but at least in my experience, I haven't heard like the best things about them. I just feel like for a more custom and appropriate pessary, you should be seeing your urogynecologist.
They come in all different shapes and sizes, so they will figure out exactly what you need.
Yeah.
Yeah. So I have the next question. So Jessie, I have constipation. I saw on Google something about a colon massage. What is this and how do I do it?
Yeah, great question. So a colon massage is a visceral mobilization technique. We typically perform this technique to help with patients who have constipation, abdominal bloating, or gas pain. The technique is performed over the abdomen along the path of the colon. You can also perform it on yourself. So I'm going to demonstrate this, and if you guys would like to participate, you're welcome to. I'm going to stand up so you can see my abdomen, but typically you would perform this laying down. So if you want to lay down, you're more than welcome to. I'm going to adjust my screen. I'm going to lift up my shirt and lift down my leggings a little bit so you can see my tummy. Okay. So to start this technique, I'm going to do it correctly anatomically on me, and I'll use the appropriate direction. So if it looks reversed to you, just listen to my voice. But we're going to start in the lower left corner. So it's kind of like you're putting your hand in your pocket. This technique is best done skin to skin, but it's a little bit lower here. So I'm just going to demonstrate over. So you're going to use your fingers, and what you're going to do in this kind of motion here is you're going to press down for about 4 to 5 seconds and then release, and then press down and release. I do this about 10 times or so. So what this does is it puts pressure over your ileocecal valve, kind of here. And it also is really calming. I find this to be very calming. So it's kind of nice. It taps into your nervous system that helps you rest and digest. Okay. After that, we're going to start in the upper left corner, right underneath your ribs. So my ribs are here, and we're drawing down the left side of your abdomen, okay? And the pressure here is strong but comfortable. You shouldn't feel like you're really digging in. It's just kind of along the path here of the abdomen, okay? Very good. So I usually do this about 10 times or so as well. After we do the left, oh, also I forgot to mention, you can go in circles as well. So you can kind of go downward and go in circles. So then after we go on the upper left side, we're going to go over to the upper right side, and you're going to go across and down. Okay, and we're going to do that same thing. So you can go, again, with those stroking type patterns, or you can go in circles, okay? And then lastly, we're going to start in the lower right corner. We're going to go up, over, and down. Okay, so we're tracing that path of the colon. And again, we can do those circles. Okay, so we're going to go in that pattern. Typically, we call this the I love you massage because of the direction. So this is the I, this is the L, and this is the U. Okay, that's the way that I do it. However, there's lots of different techniques. Sometimes people go in the reverse direction, but as long as you're going up and over towards the left side, that should help. Sometimes we'll get some abdominal like gurgling, and we'll get some motion, and that's actually good. We're kind of trying to facilitate the motion of the colon.
Awesome, Jessie. That was great. Thank you so much.
You're welcome. Okay, so before we move on to the next question, we actually have another poll. So our poll is, if you've given birth and if you feel comfortable answering this question, have you had a vaginal delivery or a C-section? So we'll give you a second to answer that. All right. Okay. So about 67% vaginal delivery and 33% C-section. So we do have a pretty good mix here today. So Devon, our next question is basically, can you talk about vaginal birth versus C-section?
Sure. So I just want to start off by saying we know this is a sensitive topic for a lot of people, but I want to start by saying that there's no right or wrong answer when considering a vaginal birth or a C-section. Ultimately, the decision is between you and your OB. So let's talk about the mechanics behind each delivery method. So vaginal delivery involves the baby being delivered via the vaginal canal, putting pressure on both the muscles and the pelvis. During a C-section, the baby is removed surgically, which requires separation of the abdominal tissue and is considered a major abdominal surgery. So you have to expect that duration of time afterwards to recover as you would any other surgery. Both vaginal deliveries and C-sections put the pelvic floor at risk for possible pelvic floor dysfunctions due to the amount of pressure applied to the pelvic floor over the course of the pregnancy. Both types of deliveries may lead to bladder and bowel dysfunction, prolapse, and diastasis recti, which we'll be discussing shortly, so please stay tuned. Vaginal deliveries, they tend to be more disruptive to the perineum, or that area between the vaginal opening and the anus. That's where the tearing occurs, so it makes sense if there is tearing for there to be some disruption there, which may cause pain and sensitivity to touch even after the tissue is healed. C-sections often require longer healing time, as I mentioned, due to its abdominal surgery to remove the baby. So Jessie is going to help to explain how to take care of yourself after a C-section if you are experiencing any pain, especially around that incision. So Jessie, how would one take care of themselves during a C-section or after a C-section?
Yes, great question. So as you mentioned, Devon, having a C-section is a major abdominal surgery where the OBGYN cuts through several layers of tissue, including skin, fat, fascia. They separate the abdominal tissue, and finally, the uterus. They cut through the uterus, and then the baby is there. So there are steps you can take to heal after the procedure. Usually your doctor will clear you for exercise around 6 to 8 weeks if there were no complications with the procedure or the healing process. You can definitely ask your doctor if you're able to start performing some really gentle exercise, something like diaphragmatic breathing, once you're symptom-free after surgery. So I'm going to go through diaphragmatic breathing really quickly. I know we went through this in part 1, but we're going to go through it again today. So diaphragmatic breathing is basically a pattern of breathing using your diaphragm and your abdominals. So you perform diaphragmatic breathing by inhaling and expanding your tummy, relaxing or dropping your pelvic floor. And then when you exhale, your belly is going to fall and you can just gently activate your abdominal muscles. This helps your healing by coordinating your breathing, abdominal muscles, and pelvic floor muscles. Another important component is performing C-section scar mobilization. You can start doing this as soon as your doctor clears you to perform it. You should not perform it if your scar is still open, bleeding, oozing, or not completely healed. So I'm also going to demonstrate the C-section scar mobilization, so I'll be in the same position standing. Again, if you have a C-section scar and you want to participate in this, I would recommend that you do it laying down, okay? So I'm going to stand up again. You guys get to see my tummy this whole webinar. So we'll pretend actually that I don't have a C-section scar. So we'll pretend that this, the border of my pants here is the scar, okay? So first we're gonna start with some desensitization techniques. And what we do for that is basically just getting the C-section scar used to having other things touch it. So a lot of people mention that they have pain wearing clothing or if their child is sitting on top of them, you know, anything really. So what we do is we first start with really gentle touch, almost like petting. You're gonna start at above your scar. So you can see I'm above the line of my pants here, above the scar. So you're gonna go horizontal, vertical, and circles. Okay, we're gonna do that above, below, circles, and on top of the scar. So right over that incision. And look, this might be really, really sensitive. So be gentle with yourself. This is the place where we start, okay? You may also experience some numbness. A lot of people experience numbness above the scar, but it's also common to experience numbness below or on top of the scar. If you experience numbness, that's okay. I would still recommend doing these techniques, okay? Once you start to get used to your finger there, you can use other, what's the word I'm thinking of, textures to go over the scar. So you get used to different materials touching it. So I usually say you can use a Q-tip, a cotton ball, you can use a washcloth or a loofah if you need something more coarse or different than just something gentle like your fingers or tissue, okay? After that, we work on mobilizing or stretching the myofascial or the skin and fascia tissue superficially above and below the scar and on top of the scar. So the way you do this is you put your hands flat and you're going to stretch that skin up and down. And you can also go side to side and rotation, okay? This you can do really gently and also in different spots along the scar. So maybe you're feeling there's a big restriction on one side and you need to work more on this side. Maybe you feel it on a different side or in the middle, wherever you feel like you need to work on it, you know, that's where you can focus your attention, okay? But I still recommend doing it in all areas. So you start above the scar, below the scar, and on top of the scar, okay? So we're stretching in all different directions. And usually to find a restriction, you'll be able to feel it on yourself, but the way you would be able to notice it is if you pull it and it kind of gets stuck. So it doesn't continue to move, it kind of gets stuck or caught on where your scar is. After we work on that, we usually do our deeper pressure. So this gets into the scar tissue right under the C-section scar. Okay, this is the most aggressive, and if you're not ready to do this, you don't have to, okay? So what we do here is by using your fingers, you kind of press in. You don't have to go perpendicular. You can keep your fingers kind of along the scar, and you can go in circles. Again, you can go up and down, or you can just kind of apply pressure and hang in there, okay? You can do this again above and below the scar as well. You'll probably feel the most restriction along the scar, okay? If you're feeling some scar tissue, it may feel a little nodular, like little kind of balls underneath the tissue, and that might be a good place to start, okay? I usually prescribe my patients C-section scar mobilization 1 time a day for 3 minutes. And I'll say it's the length of a song or a commercial break or something like that. And it doesn't have to be super skilled. You can do it, you know, just kind of play around with it if you need to just get used to the sensation there. And this applies to all scars, whether you have a transverse scar, if you have a vertical scar or any kind of other scar. This scar mobilization technique is really for anything. Super important though that you do get clearance from your doctor to make sure that everything is healed. We do not want to be doing this before you're ready.
Yeah, Jessie, that's great. I would also just add too that you might want to have your partner or someone else you like touch the scar and touch the area once you feel comfortable and once you don't feel pain with yourself, just to take away that sense of control. If your child does end up kicking or touching your belly, you don't want to be caught off guard and cause pain. So
yeah, absolutely. And you know what, we will also be having another webinar on postpartum and pelvic floor as well as scar. So we're going to go over this again. So, you know, stay tuned for our other webinar if you want to learn more about postpartum scar mobilization.
Great. Thanks, Jessie. That was great.
Yeah.
So I'm going to move on with the next question. So my tummy doesn't feel the same after giving birth. I've heard of diastasis recti, but I don't really know what it is. How do I know if I have it and what can I do about it?
Yeah, great question, Devon. This is maybe one of my top questions ever asked to me when I see a patient who is either pregnant, postpartum, or has had kids once in the past. So I'm glad we're addressing this. So diastasis is very common during and after pregnancy. Diastasis is when the left and right side of the abdomen separate. And this happens during pregnancy in order to accommodate for the growth of the baby. So a lot of people ask, what can we do to prevent this? What can we do, you know, to make sure I'm not going to have diastasis? sometimes it is just a part of being pregnant. Your baby is growing and we need to accommodate for the space of the baby. So this sometimes just happens, and we couldn't have done anything to prevent it. So I just wanted to address that as well. So this diastasis can also persist postpartum. This usually presents as a bulging of the abdomen or a divot in the middle of the abdomen with increased effort, like sitting up out of bed or doing a crunch or doing a plank. We measure diastasis by finger width across the abdomen, depth in which your fingers sink down, as well as the contractile strength of each side of the abdominal muscles. So the treatment for diastasis is to work on deep abdominal strengthening. This includes a variety of core stabilization activities in different positions, as well as learning abdominal activation during daily activities like squats, lifting, running, or even jumping. So the one downside about diastasis is there's not a lot of research on predictive factors for successful closure of the gap. So our goal in physical therapy is to help you get stronger to perform your daily activities and recreational activities with good form and also pain-free. So although we're certain with physical therapy that you will get stronger, especially if you're compliant with your homework and you're coming into your appointments, it's unclear whether these same techniques will also improve the cosmetic appearance of the separation. This is highly variable patient to patient. So if you're experiencing diastasis, you can definitely try some of these deep abdominal strengthening activities. But I usually tell my patients, come in for a session. We'll, you can consult with your PT on appropriate interventions to address the diastasis, because each treatment plan is really unique to your needs, as well as the severity of the diastasis.
Great. Thank you, Jessie. I think that's going to be really helpful.
Yeah. Okay, we're shifting gears a little bit here. I think we are going to talk about some pelvic related surgeries and surgical recovery. So this next question is, I'm a trans woman who just underwent vaginoplasty. My doctor recommended pelvic floor PT. Will that be helpful?
Yeah, so the answer is yes, like yes, 1,000 times. After undergoing a vaginoplasty, pelvic PT is highly recommended to ensure success and improve comfortability within your body. Dilation or opening of the vaginal canal is one of the primary focuses of pelvic PT after undergoing a vaginoplasty. So the body's natural response following any surgery is to heal, which means the body wants to close the wound. In this case, we do not want that. So we need to make sure that we are maintaining that open canal, that open neo-vaginal canal, which is the purpose of the surgery. So we want to make sure that it's successful as possible. So in addition, though, to dilation, which is a series of dilators that you can use with your therapist, we also like to look at the pelvic floor muscles themselves, because the surgery is traumatic to these muscles and it does rearrange them. We want to make sure that they're still working properly and they're strong to prevent any kind of bowel or bladder dysfunction. But there's also been studies to show that pelvic floor physical therapy prior to undergoing this vaginoplasty surgery has been really, really helpful in reducing those bladder and bowel dysfunctions and just overall improving success and your, and feeling good in your new body. So I definitely think that pelvic PT is wonderful for this type of surgery, before and of course after.
Great. Yeah, thank you. I think this is, such an interesting topic to cover, and so important that we have the appropriate education. So I'm glad we received this question.
Me too.
Our next question is pretty similar in terms of our surgical, pelvic surgeries. So our next question is, I recently had a hysterectomy. Should I be doing pelvic PT after the procedure? When should I start?
Yeah, so this is a great question as well. A hysterectomy is a surgery to remove the uterus, either through the abdomen or the vaginal canal. Both types of surgery may compromise the pelvic floor and abdominal muscles, causing weakness, pain, and possible bladder and bowel dysfunction, such as incontinence. It's never too late to see a pelvic floor therapist after having a hysterectomy, whether you're experiencing symptoms immediately or many years down the road. Pelvic floor PT can help to improve pelvic floor and abdominal strength, improve abdominal mobility, tenderness, and pain, and of course, improve your bladder and bowel function.
Yeah, absolutely. I think too, if some patients who have hysterectomy, maybe they're not feeling severe bowel bladder or sexual dysfunction, but they do feel like deconditioned and just their pelvis is a little bit weaker. So I think pelvic PT has such an important role when it comes to, just getting back into regular activities like walking or recreational exercise with a specific focus on the pelvis and the surgical precautions.
Right. I think we think about all different types of surgeries as having that post-op PT, like a knee surgery, you talk about having PT. These surgeries are no different. So whether it's a C-section or hysterectomy or vaginoplasty, there's always help.
Right. Absolutely.
Yeah. So Jessie, I have the next question. So I have a labral tear and I've noticed some pelvic pain. Could this be my pelvic floor or my hip? What's the deal?
Yeah, this is a great question. So I see a lot of patients who have concomitant hip pathology like labral tear and pelvic pain. For those in the audience who don't know what a labral tear is, it's something that can happen in the hip. Your hip is a ball and socket joint, and there is a lining in the socket, which is called the labrum. It acts as a suction cup and improves the congruency of the joint. The mechanism for a labral tear can be traumatic or non-traumatic. So typically in non-traumatic labral tears, the usual hip stabilizers become weak and the pelvic floor becomes overactive to help do the job of stabilizing the hip. This will present in dysfunction in itself, including urinary urgency and frequency, and sometimes pain during sex. In this situation, the treatment approach will usually include working on releasing the pelvic floor muscles and learning relaxation techniques and pelvic floor coordination, while also strengthening the glutes and surrounding hip musculature. I really love this question because it's kind of related to what we all do as orthopedic physical therapists, but it has this pelvic floor component too. So it's really important that we're considering all, parts of the body.
Definitely.
Yeah.
All right. We'd love to open up the floor and bring Lisa back in to help answer all of your questions live.
Hey guys, what's up? That was great. Obviously, just as informative as the first one. It's really awesome to sit here and get to learn with you guys. So we have a ton of questions, so I'm going to do my best to get through all of them. Okay, so the first one is about the scar mobility. What if, can we do this on any scar? And then two, what if your scar is older, let's say many years older, is there still benefit to doing it even though there's been some time?
Yeah. I mean, I always think that there's benefit to doing scar mobilization. I think that if you're experiencing dysfunction in that area, no matter how long it's been, I think that trying to do something is certainly worthwhile. I've seen patients who've had C-section very, very long time ago. So yeah, I think that it's totally worth it.
Agree.
Awesome.
Yeah. Oh, wait, I feel like there was a first part of that question though that I didn't answer.
Oh yeah, you can do it to any scar. That's for sure.
Yeah, that was the first part.
Thank you.
Okay,
Yep.
Perfect. And then in terms of that, can you just show us again one more time where the colon massage, where you do it? And then while you're doing that, thinking through, like, are there any other massages you would recommend for constipation or IBS?
Yeah. Okay, so I'll show again. So I'm going to, and we can all see my belly button, right? So we start at the ileocecal valve, and at least I do. Some people do it a little bit differently, but it's basically like you're putting your hand in your pocket, the lower left side, okay? So we start in the lower left side, we go down the left side, and then we go across from the right to left and down the left side again. And then we go from the bottom right up, across right to left, and then left all the way down. I think that was it, yeah? Oh, the other techniques. Devon, did you want to cover the other techniques?
So I actually do something different. So don't be alarmed if you're my patient and you're watching this video. I did not teach you wrong. This is a different way. I always start on the bottom right-hand corner just to kind of get the process moving. So I do little small circles starting in where Jessie ends. That's where I would begin. And you just make your way across in one big rectangle across all those points that Jessie just pointed out. And just making small circles with your hand with a flat hand or flat fingertips. And applying gentle pressure just to keep things moving. I recommend doing that a few times a day if someone's struggling with a slower motility of their colon.
Very cool. That's awesome, guys. Somebody asked a general question to cure pelvic floor dysfunction. How long should or does pelvic floor physical therapy usually last? It's more in general about rehab.
Yeah, that's a good question. And look, I mean, pelvic floor dysfunction can present in so many different ways. So if you have a more simple case, like let's say you have just stress urinary incontinence, you gave birth 3 months ago, and you have pelvic floor weakness, you know, that typically I would say takes about like 2 to 3 months. I don't know, Devon, if you have a different
No, that's
explanation
what I
of
would
that.
say.
Yeah, if you have a more complex case, if you're experiencing chronic pain with multiple different comorbidities, this is a little bit more complicated to assess because sometimes people will respond immediately to physical therapy and it takes that regular 2 to 3 months as well. Sometimes it does take a very long time to unlearn a lot of the bad habits or pain mechanisms that you've established over many years. So a lot of times we'll do, like I usually do, more aggressive in the beginning. So we'll do like a couple times a week for a few months. And then we kind of get on like a maintenance program where we reassess how you're doing, you know, twice a month, once a month, something like that. I don't know, Devon, do you have a different?
Yeah, no, mine is very similar. I agree. Everybody's a little different, but I think 8 to 12 weeks is a good marker at the very least, just to see how you're responding. But you do have to give PT some time and be as consistent as possible with your home exercises. That's really what it comes down to at the end of the day.
Awesome. Thank you, guys. So there's been some questions just about bladder habits that I thought would be great if you can touch on. Things like, should I go every time I need to? Should I hold my pee? Or should I go just in case? Like if I don't even have the urge, should I go if I wake up in the middle of the night just in case? Or should I go before I leave the house? Can you guys address that sense of maybe urgency or lack of urgency and just good habits?
Yeah, so that's a loaded question. A lot of people.
It's a lot.
Yeah, but a lot of people do all those things. It's good to listen to your body. You don't want to be holding urine for hours and hours on end, but you also don't want to give in to every urge, especially if you went within the hour or very close together. So there's a couple techniques we can do. You can do some quick flicks, which is a quick pelvic floor contraction, followed by a quick release. So you don't want to hold. It sometimes makes the urge more severe, but you just want to do a quick squeeze and a quick relax a couple of times and see what happens. Give your body some time to adjust, and it should help to reset the pelvic floor, even like just to relax your pelvic floor and relax that urge to see if it was a real sense or not. Usually it will get by you at least a few minutes, so you're not rushing. But you really want to try to push it so you're, you know, going within that 3 to 4 hour, like every 3 to 4 hour norm. But it may take some time to get there. But that would be a technique I would use to try to delay that urge.
And then, you know, Lisa, you mentioned like going without the urge. Like there's no reason to do that. Like if you wake up in the middle of the night, just go back to sleep. If you have no urge to go and it's before you leave the house, I know this causes a lot of anxiety for people. If you're going somewhere and you know it's going to be like a 20-minute walk, just don't go. You know, I get it if you are going on, you know, a 5-hour road trip and you want to go before you leave the house. Like, okay, you know, you don't have to go 3 times before you leave the house, just go once and then you should be fine. So we don't want to establish these poor habits where you're consistently going every time you pass the bathroom when you don't have the urge. So, you know, you don't really want to go if you don't have the urge. But you know, we can't be too strict about it. So if you're going somewhere and you have to hold off for several hours, I get it, right? But you don't want to go if you don't have to.
Awesome. Okay, so kind of switching gears, and there was a bunch of questions about diastasis recti, so I'll ask these as best as I can. One, I know you spoke about it a bunch, but can you speak about how exercise can help heal it, and then maybe what exercises are good for it? And do you see conservative management being effective? Do you not? Like, is that something someone should always like look for, or are there other ways to manage it?
Yeah. So I've found that conservative treatment for diastasis is something that's very effective. It may take a little bit of time, but you can definitely see some results. But as Jessie said during the webinar, there's not a lot of research to prove a lot of this stuff that we see to be true. So when I always tell my patients is I always say, it's not really about that number. It's a finger width test. How many finger widths are, the separation that we can test in PT. But it's more about how you feel and how strong you feel. And of course, how you look, that is a big part of it. But I don't like to get caught up in that number. It is important to know, we have to have a good baseline, but I always say that number may change, it may not. There's no research to back that up, but there definitely are exercises that are really, really helpful to help you feel strong and feel more comfortable in your new postpartum body.
Also, I will say we did not provide this information before. A finger width separation of 2 fingers or less is considered clinically insignificant. So if you have a 2-finger width diastasis, that's considered to be within normal. If it's more than that, then maybe it's something that you do want to get checked out. You need to listen to your body, see what's going on. If you're noticing a bulge or a divot when you're doing exercises or getting out of bed, that would certainly be an indication to get that taken care of. When it comes to specific exercises, it really depends on where the patient's at. Sometimes breathing in itself and abdominal bracing, so just like activating your core, is enough to start out with. Sometimes people are beyond that. So I think what I mentioned in my question was, or in my answer to the question was that I like to get it assessed because we can see where your baseline is. Some people, their baseline is starting with breathing, and other people, their baseline is starting with, planks, usually not, but like maybe. So it's kind of hard to say, what exactly the exercises are, because you may be starting in really different places. But you can know that in general, deep core strengthening, including diaphragmatic breathing, including bracing or activating your core, that's a good place to start.
Cool. And I guess another question that came in was, if you don't see an improvement in that gap, how do you know the exercises are being effective?
So you should feel stronger. So you should feel like, oh, I can better able to do these exercises that I couldn't do before. Now I can lift my 23-pound child much better than I did before. The closure of the gap is not everything. And I know that's really hard for a lot of my patients to hear. There are also multiple factors that go into closure of the gap aside from strengthening. One is breastfeeding, which, you still have different hormones in your body. And once you start breastfeeding, it may take even up to a year after for the gap to improve. So there's a lot of time involved and a lot of different factors. So aside from just looking at the gap, you should look at, how you feel, how strong you are, what you're able to do physically.
Cool. What if it's been many years? Is it still worth trying to do these exercises? Is there a potential for improvement?
Yeah, I think there's always potential for improvement. Just like any muscle can get stronger, your core can get stronger. It's never too late to come in and start a program.
Okay, great. I'm going to do the best we can to get through these. If we go a couple minutes over, it'll be worth it because this is so valuable. Let's talk about Kegels. There was a bunch of questions about that. Wondering if you could address Kegels in general. How do you do them properly? Can they ward off incontinence? And then what are some exercises maybe aside from Kegels that are safe to do in pregnancy to keep your pelvic floor strong? 3 in 1.
Okay. I'm trying to think back to that first question, Lisa.
How do you do them properly, number 1, and then addressing can they ward off incontinence? Are they helpful in that way? And then we'll talk about other exercises during pregnancy.
Yeah, so I can tackle that first part of that question. So you want to make sure that when you do a Kegel, it's really small. It's a lot smaller than people imagine or want it to be. If you're getting your glutes involved, like if you're squeezing your butt together, that you're doing a little too much. Or if your inner thighs start to quiver, they're getting involved, you want it to be totally isolated to just the pelvic floor. So it should just feel like you're gently holding in urine or gently holding in gas. It may feel more anterior or forward or front for some people and more posterior for others. That's all working the same muscle, just as long as you're not getting those bigger muscles involved. It's a really nice place to start, like Jessie mentioned, with the blueberry, like pulling in a blueberry or grabbing a tissue, something really gentle, like really little and small. A lot of times people are just doing way too much.
It does help with incontinence. So incontinence usually is happening because the pelvic floor is weak. However, there are types of incontinence where actually the pelvic floor is a little over tightened. So I wouldn't go like full throttle on the Kegels right away. This is something probably you should get assessed if you're unsure whether you're in the tightness category or in the weakness category, or maybe you're in both. So you do need a little bit more attention for that.
Okay, that's really helpful. Let me see. In general, crunches, like exercises about, like a lot of crunching exercises or sit-up exercises, are those bad for the pelvic floor? Are they good? What's your take?
That's interesting.
That's a tough one. I think the internet kind of goes crazy for this question. For me, like Jessie, you might have a different response, but for me, if you're not doing Kegels and, if you're not doing crunches and sit-ups all day, normally, why start? But if you're getting up out of bed and that's a sit-up, you're sitting up in bed, that's okay. It's nothing's bad, but it does, if you're not breathing correctly, can apply extra pressure down in the pelvic floor. So it's really important that if you are doing these types of exercises, that you're doing them correctly. And it might be worthwhile to get your form checked out by somebody, just to see if it's right for you or if it's not.
Yeah,
Awesome.
And usually if there's tightness in your pelvic floor, some activation of the abdominals will contribute to hyperactivity of your pelvic floor. So that's something, usually if you love doing crunches and you have an overactive pelvic floor, I'll work out with my patients on how to simultaneously relax your pelvic floor while activating your abdominals.
Awesome. That's great. There were some questions about pelvic pain. So someone asked, like, where should someone start with getting chronic pelvic pain diagnosed? Is it OBGYN? Is it physical therapist? Is it a family doctor? Just to get your take on where you think the first step is.
You want to take it?
Any of those are fine. I would say because we are specialists in the pelvic floor, we can assess the pelvic floor muscles, which a lot of the times are involved in chronic pelvic pain, but we also have the ability to assess if it's not a pelvic floor muscle dysfunction, that we would refer you out to the gynecologist or whoever is the appropriate referral. So you definitely could come see a physical therapist first, a pelvic floor physical therapist, and then, we can guide you in the right direction from there.
Awesome. That's really great to know. Another question came in, like, what can cause penile or testicular pain with erection and ejaculation if it's not the prostate?
Yeah, so typically that's from those hypertonic pelvic floor muscles, or muscles that are a little bit too toned or activated too much or too frequently. So those can be reduced by not doing Kegels, doing more relaxation, stretching, a stretching type of program. We call it down training. So trying to slow those muscles down a little bit. Yeah.
Cool. And then if someone has history of pelvic pain in the past, would that be something that could interfere with having a vaginal delivery in the future?
Good question. I guess it's possible. I would definitely recommend going to see a pelvic floor physical therapist to prepare you for birth. So we'll work on relaxation techniques, we'll work on breathing, we'll work on stretching the perineal tissue, so that tissue between the vaginal opening and the anus, so that everything can move and relax appropriately for delivery.
Great, that's awesome. Another kind of thing about pain, maybe, what could cause difficulty with inserting a tampon? And would this change if someone is sexually active versus someone who has never been sexually active?
Typically, that doesn't always matter. If you have pain with tampon insertion, it's likely that you will have pain with penetrative intercourse as well. So that's something that we can definitely work on with the dilators, as we mentioned briefly today, just to keep that vaginal canal open and pain-free. We can also utilize some of the same techniques that Jessie was using with the C-section scar, that desensitizing, that can be used for the pelvic floor as well, just to get the body and the tissues used to touch and used to finger or tampon or other things. Yeah.
That's great. Awesome. This is a great question. I think this is something that we all probably wonder about is, can you have both hypertonic and hypotonic pelvic floor muscles at the same time or issues? And if so, how do you go about managing it? If it's one or the other, or if it's both?
So it's very possible that you can have, I wouldn't say hyper and hypotonic because we're talking about the muscle tone itself. Usually we're diagnosing one or the other. However, let's say you have hypertonic pelvic floor, so that's overactive. You can also have weakness. So just because it's overactive doesn't mean it's strong. The way that we address that is usually by relaxing the muscles first, because let's say, you know, if this is your pelvic floor and it's squeezing tight and we're trying to strengthen and do Kegels, you know, doing this isn't going to be very effective. We need to get your full range of motion first, and then we can contract and relax from there. Depending on what your dysfunction is, I mean, the interventions are going to vary a lot. Sometimes we need to focus solely on relaxation. Other times, like what I just mentioned, we, you know, release and then we work on strengthening and coordination.
That was great. One last question before we run out of time. This has been really super helpful. Kind of in relation to that is endometriosis something that could be associated with hyper or hypotonic muscles? And if so, which one? And what would you do to go about treating it?
Yeah, that's a great question. So typically endometriosis, we do see hypertonic muscles. It's just a response to pain, and we can see that anywhere in the body, but the pelvic floor is especially sensitive to stress and pain, especially in the abdomen. So that's typically what we see, but we can definitely see a variation of that. We can never know what to expect, but that's something that can definitely be managed with physical therapy. We are having a pelvic pain webinar coming up in the future months, so keep your eye out for that. That's going to be helpful in answering these kinds of questions.
Awesome. You guys are so fantastic. It's been a pleasure being on this with you for the second time. Such valuable information. We hope today's talk was valuable for all of you and that you learned a few more ways to prevent and perhaps manage some of these symptoms that you may be experiencing, as well as better understand the pelvic floor. If we didn't get to your question, we will do our best to reach out to you directly after. And we'll also be sending out a handout on all the important facts as a reference in addition to that. As they mentioned, we will be hosting more pelvic health webinars in the future, as well as ones with other topics. We do them on Thursdays, so we look forward to seeing you there. At Spear, just as a reminder, we treat an array of conditions from head to toe, and we're open for in-person visits as well as telehealth. So should you feel you could benefit from any individualized treatment and guidance, please don't hesitate to reach out to any one of us. We personally like to help you coordinate being set up for an appointment with the right people. So thank you all very much again for spending time with us today. We hope you enjoyed the webinar and we wish you all the best. Thank you guys.
Thank you. Bye-bye.
Bye.